Welcome to the Virtual Shift, a show looking at the seismic changes happening in healthcare with virtual care at the epicenter. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and the future. Hello, and thanks for tuning in today. I'm your host, Tom Foley. You can learn more about this show by visiting the program on healthcarenowradio.com, and be sure to follow me on LinkedIn, Twitter at FoleyTom, and the hashtag The Virtual Shift. Today, we are going to take a slightly different approach, and I am going to interview myself. And I say that from the perspective of I've been doing the Virtual Shift now for over 100 plus episodes. I've spoken to many thought leaders across the spectrum. And as you know, I am the Chief Growth Officer of Genie MD. And I wanted to give my perspective of where I think we're at in the current state of healthcare and where we might go in 2025. So with that, let me just start off with the position that I think the current system is basically broken. And the things that amplify that are this. We have a delivery of care system where it takes the patient 26 days to get a scheduled visit with their physician. Even given the fact that they are sick today and have to wait almost a whole month for a scheduled visit is a challenge. The National Institute of Health had a study that says 32% of ED visits could be classified as non-urgent. 76% of hospital admissions based on a chronic condition such as heart failure, COPD, diabetes, and others, could have been avoided. Of all the hospitals in this country, over 5,000 of them, by the way, and I think about all the beds, and 76% of the admissions due to chronic conditions could have been avoided. And we talk about the cost of care, and I think that's a huge challenge. 90% of healthcare spending in the U.S. is due to conditions like heart disease, diabetes, and obesity. These are chronic conditions. So as well, I should say that even on a cost side of the equation, just in the last 5 years, physicians are being paid 10 to 12% less due to the reduction of fees outlined in the physician's fee schedule published by CMS. As well, with inflation, over the last 5 years, there's been 20 to 22% based on study about your ability to spend. So that's a huge hit for providers to get paid less and to be hit with inflation and expected to do more. It is quite the challenge. And I'll add that with all the advances in medication, care models, we have more people with chronic conditions today than yesterday. When I talk about on previous sessions, I've always talked about having an older age or sicker population, and we have less doctors and nurses to care for that population. That is ultimately the challenge that we have to overcome in 2025 and beyond relative to what does that new delivery of care model look like? How do we address how better to engage a patient that has a chronic condition and ultimately achieve a better degree of care? That said, that's ultimately the direction that I want to talk about. And I'll be remiss to remind everybody about, again, something that I constantly repeat, and that is that the average Medicare patient with 5 chronic conditions sees 9 different doctors in a given year. They're only in front of all of their doctors 15 hours in that year. The question is, relative to how do we care for chronic conditions, is what happens the other 8,745 hours when they're not in front of their doctor? That's where wellness is achieved. And if you don't have a support system in place, you're not going to achieve the degrees of wellness necessary to change the trajectory of the challenges with more people with chronic conditions today than yesterday, and changing the cost curve relative to what it costs to deliver care. So with that, let me just say that the engagement, from a patient engagement perspective, there are some very significant opportunities. Patient engagement When we talk generically, one would argue that patient engagement, there's been many studies. As a matter of fact, the Agency of Health Research and Quality, AHRQ, CMS, and even the Institute of Medicine have all come out with studies that reflect that patient engagement has shown to improve health outcomes, become to foster proactive, informed participation in one's own health, where patients are more engaged, they are likely to understand their treatment plans, adhere to prescribed therapies, make lifestyle changes that support health. This active involvement helps reduce the hospital readmissions, improves chronic disease management, and often leads to higher quality of life. And isn't that what we're all trying to achieve in this process? It's not just about how do we reduce costs. It's really about quality of life. And these engaged patients are generally more satisfied with their care, which builds a positive feedback loop and further encourages adherence and better outcomes. And at the end of the day, again, if this is this is the change. And the change is, how do we engage? It's not what happens when you're in front of the doctor. It's what happens when you're not in front of the doctor. That is the greatest influence in care. The doctor is going to tell you you have diabetes. The doctor is going to tell you you are obese. The doctor is going to tell you you have cardio problems. And they're going to prescribe a pill, most likely. And they're going to tell you, hey, you should diet and exercise. But when you go home, is that truly what happens? And the answer is probably it doesn't happen. And I say that in general because we have more people with chronic conditions today than yesterday. And obesity and diabetes and cardio issues are the top three areas of spend. And I often say that if you're obese, it doesn't mean you have to die as an obese person. If you had diabetes, doesn't mean that you have to die with diabetes. The care plan, the objective is, how do we help you lose weight? How do we help you with your A1C? It's not about taking the pill to manage the problem. It's about how do we prescribe a care plan and objectives to cure the problem. I often relate to to an old show called The Biggest Loser. And the contestants on this reality show would walk into this facility with a bag of pills and grossly overweight, but they were being managed by a physician. And at the end of the day, the biggest loser was the one that ultimately walked out with their ability to have lost tons of weight. They're no longer on medication. They're no longer diabetic, and they're no longer obese. I'm not suggesting that we go on, everybody join a reality show, but under the care of a supervision in the presence of your own home, those same objectives could be achieved, but you're not going to get that coaching hypothetically in the physician's waiting room. And let me give you a little personal story where I come from on this as well. That my father, who you might have heard, was an obese person, and he had diabetes and he had cardio issues. He did do dialysis at home, but diabetes technically doesn't hurt. You don't feel pain when you're a diabetic. When you're obese, you're obviously a lot of discomfort and your mobility is challenged. But at the end of the day, diabetes doesn't hurt. However, in the last 5 years of my father's life, he lost a leg. He just got his prosthesis and started walking again, and then he lost the other leg. And then a few months later, he lost the forearm of one, and then 2 fingers on the other hand. So I've seen the impact of diabetes and obesity maybe from a different perspective than most, to the extent of which a dining room is converted into a downstairs bedroom. You have to install a full bath, handicap accessible, of course, downstairs. And this was a 3-bedroom, 1-bath home that when we were young, we supported 6 kids and 2 adults. And yeah, you install a ramp to get into the home. You sell your car and you buy a van for transportation purposes. A van that actually has a handicap ramp so that the patient can get in. My father never drove that, but he was definitely transported in his own van. But the point there being is, it's more than just a medicine that needs to be prescribed. And it's more than just the one individual that is impacted here. It's a family. It's a community. We always said my mother was lucky to have 6 kids because we were all caregivers in different ways. But you look at the quality of life and you look at how that could have all been different. This is because, in the late 90s, there wasn't anything referred to as value-based care. There wasn't anything thought of about how do we engage a patient in their home. There wasn't remote patient monitoring, chronic care management, at least not to the degree that it is modeled today. So the point there being is there needs to be a different model. And the model really is centered on two basic fundamentals. And the fundamentals are how do we engage patients in their home? Or said differently, how do we engage them where they're at? And what does that extended care look like? In today's model, we have constructs of telehealth, remote patient monitoring, chronic care management, remote therapeutic monitoring, transitions of care management, behavioral health efforts, and even in the 2025 physician fee schedule, we have something referred to as advanced primary care management. These are all models that are fundamentally funded and can produce significant impact relative to the idea of how do we engage patients where they're at. So turning that home into a center of care, implementing a patient engagement strategy through these virtual modalities are all ways in which we could change the paradigm in how patients, again, spending 90% of the overall healthcare spend, can receive care. And so the idea is, and not to just enroll a patient in remote patient monitoring. I've argued, now again, I work for GeneMD, and I argue that monitoring someone's blood pressure is good, and there's 16-day compliance, so you get reimbursed. That's good, but did the patient get better? And that's ultimately the point. It's not engaging in these virtual modalities for the sake of engaging in the virtual modalities where the provider gets more or gets paid more. It's a combination thereof. Did the patient achieve better outcomes, and is the provider properly compensated? Right? They're not a charity, and no one's asking them to be a charity. So the point is that we have models. So I would add that a remote patient monitoring program, while it's not part of the reimbursement schedule, that patient should have a care plan. And it might not be quote unquote a comprehensive care plan that you see in a chronic care management program, but the idea of, hey, we know this person's hypertensive. We know this person's on medication. Why isn't there a care plan? So it gives something for the care manager and the patient to ensure that they're compliant with. And the compliance often leads to outcomes. So the idea of, hey, because I know that, typically if someone is not compliant with taking their blood pressure in this remote patient monitoring program, the first thing we're going to ask them is, are you taking your pills? Are they working for you? Are you able to get refills and things like that? It comes down to medication. So why not incorporate that into a remote monitoring care plan and objectives? So, and quite frankly, GeneMD adheres to the American Heart Association guidelines of. It's not just about the 16-day measure. Again, we tell our patients, we don't even talk to our patients about 16-day measures. We talk to the patient about taking their blood pressure twice a day, and we follow the American Heart Association guidance: once in the morning, once in later afternoon. The morning measure is more of, supposedly, is the way I look at it, is more of a relaxed state. You wake up, take your blood pressure. And the mid-afternoon, late afternoon, it's after potentially a day of activities, and you're taking your blood pressure again. When the results come in and, it maybe breaches a rule that says, hey, this is you're very elevated, or you're just a minor elevation, which we would refer to as a warning, it gives the care manager reasons to engage. And if you're not breaching the rule, that's good too. That means we're all on the same page relative to getting this patient to a healthier state of wellness. So the point here again is, look at your programs. There's more to it than just chronic care management as an example. The rule says you have to have, or for remote patient monitoring, remote therapeutic monitoring, you have to have one interactive call per month. That's true, but I want to make sure in a care plan that they're being taken care of. Just having one interactive call, that means there's 29 days in a month you hadn't talked to them, right? The question, remember, the question is, how do you close the gap in that 8,745 hours in a given day? If I'm not talking to them, if I'm only calling them once every 30 days, once a month, then yeah, there's value in it, and you're going to learn something and you're going to react to it. But we could do better because we want to make sure that they are taking their medications and they are dieting, they are exercising, and they're moving towards a common objective. Because regardless of what modality you're engaged in, you still want the opportunity to educate the patient, which is going to allow them to maybe change their thought process in the context of then changing their behaviors ultimately to engage and achieve the objectives that you set out. So those are some of the really key elements of how do we leverage today's model, enhance it so that we're ultimately using the current models that are available to us to achieve better care. Now, I will say that, a provider might say, hey, I don't have the resources to provide care management services in the home. My nurses are busy just doing brick and mortar business. And that's where a good remote monitoring service can come in and help supplement those plans, those efforts. They're kind of an extension of your current practice. As a matter of fact, they can only operate at your direction. So understanding your care protocols and the way in which you want them to act in the context of how do I react to X, Y, and Z is all at your direction. They should not be operating independently. It is your practice and your business, and you ultimately, provider, are the ones accountable for the reimbursement. With that, let me just say that we could do better, and we have to be a little bit more diligent and a little bit more thorough. So if you are going to engage in providing extended care into the home of your patients, think about telehealth, think about remote patient monitoring, think about chronic care management, think about remote therapeutic monitoring, and a comprehensive plan will allow you to put together these strategies and implement these strategies. And it could all be in a fee-for-service model. I'm a big proponent that says I can get you to value through fee-for-service, because the fee-for-service is going to demonstrate that you can achieve better outcomes. I can monitor, I can engage, and I can change behavior, and we can achieve the outcomes necessary. If I can demonstrate compliance to the measures and adherence to medication therapy, and therefore show that they are not going to the emergency room for services and not going to the hospital for services, those are the elements of value-based care. And I'm proving it in a fee-for-service model. Now that you have that confidence and understand, well, geez, how do I, you might be asking yourself, well, how do I get the value today? Right? I have no confidence in how to do it because I've never done it. But by implementing these fee-for-service models, I can demonstrate that to you, and you now have confidence on, yes, I know how to reduce emergency room use. I can reduce hospitalization. I can improve medication adherence. That patient is going to come to me or maybe not come to you, but being seen by your staff and be happier about it as suggested in the positions previously discussed from the Agency of Health Research and Quality. At the end of the day, patients are more satisfied, remember, with their care, and therefore willing to be more open and provide you that feedback. Isn't that what we want? An open dialogue, and moving that patient to a different state of wellness. So now let's look at, okay, I've demonstrated these programs. The provider has been able to adopt these programs, demonstrated they can achieve greater measures through a fee-for-service model. Now let me think about, geez, how do I achieve the CMS objective that every provider, 100% of those providers, by 2030 must be in a risk-oriented program. So the question ultimately is, how are you going to get there? I can start with adopting programs that are reimbursable today. And those reimbursement programs can help your patients achieve better outcomes, and you get compensated, the provider get compensated for those efforts. Now let me switch to, okay, I need to take on risk. I'm confident that I can do that. Here's my program. I'm going to enhance it a bit more. I'm going to take on some more data, and I'm going to be more diligent in maybe what a care delivery model might look like. And that actually brings me to the 2025 fee schedule, CMS physician fee schedule. And because there's a model in there called advanced primary care management, it's very much like the virtual modalities that we just got done talking about: remote patient monitoring, chronic care management, medication adherence, remote therapeutic monitoring. The point there being is this: instead of counting 20, 40, 60 minutes, instead of counting 16-day measures, which creates some administrivia for the practice in and of itself, let's really focus on care. Let me pay you because you are the primary physician of record for that patient. And I am going to engage you in a very similar model and establish a comprehensive care plan with stated objectives that both you as the practice and they as the patient have, I won't say have to achieve, but are strongly guided to achieve, right? Part of today's health system is not necessarily the system in and of itself. It is complicated. It is expensive. It is confusing. But the point there is that we can simplify it to the degree of how we provide the service. Who is that angel, that care manager that engages you on a day-to-day basis, not once every 29 days, 30 days. And ultimately, they feel like they can engage in the same program, maybe a little bit more thorough and comprehensive, but I am still working towards value. I'm not in the hospital as much. I'm not in the ER as much or at all. And I am driving towards, again, better care. So I've been rambling a lot, and it's tough to interview oneself, but I hope this gave you some food for thought. Virtual care, hence the reason why I called this program the Virtual Shift. Virtual care, through the adoption of these innovative programs, can be very, very beneficial to your practice, can be very, very beneficial to the patient and the overall health system. The goal here is not CPT code criteria. The goal is outcomes, and be able to measure those outcomes where the patient ultimately has a better quality of life. And if we could do that if we can achieve that end objective, then the patient is going to be engaged, and the patient is going to be the driver of those outcomes, because one might argue, not to revert here, but one might argue that today's care delivery system is really because of a lack of patient engagement. We're going to flip that. We're going to flip that on its head and engage them, educate them, motivate them, hopefully encourage them enough to where they change their own behaviors and engage in the objectives stated in the care plan. And if we could do that collectively as a market, and we will be much better off. And I don't want to get into politics here, but I will say that I am so happy that we are going to be focused on chronic care management in 2025. And I think if we can embrace a model that is really there, we just don't implement it as well as it could be, we can facilitate and help in that effort to reduce the overall cost associated with chronic care management, and allow patients to have a greater quality of life, and allow us to all move forward in a more healthier way. So with that, I will pause here and thank everybody for listening. If you have any questions, you can certainly reach out. I'm available on LinkedIn. You can always connect with me and send me a message, or send me an email at tfoley@ehealthrecords.com. And I'd love to chat with you about your particular challenges and how you might go about adopting these programs and being that innovator that we all need every practice to have in order to achieve to deploy a different care delivery model moving forward in 2025. Hopefully that helps you. Look forward to speaking with you, and have a blessed day. Take care. That's today's shift. I appreciate the audience taking the time to tune in. If you missed part of today's episode, you can tune back in at the healthcarenowradio.com at the same time, 11 a.m. or 7 p.m. Eastern throughout the week. And be sure to check out the program page at thevirtualshift.co. As well, remember to follow me on LinkedIn, Twitter at FoleyTom, and follow the show's hashtag, TheVirtualShift. I'm Tom Foley. Until the next shift.